Okay, so this video is going to examine the drugs that are deemed chromatin function inhibitors. There's two main chemical classes. The first class are the epipodoflotoxins, try to say that 10 times fast, and the camptothecins. The prototype for the epipodoflotoxins includes etoposide and tenofovir. And these are semi-synthetic glycosidic compounds that are derivatives of the podoflotoxin, which is shown here. This is a natural product or a natural compound produced by the roots of this plant. Ironically, this plant is native to Illinois, and if you ever hike in the woods around Chicagoland, you can see this plant kind of coming out of the ground in early May. That's why it's called the May apple. And it grows about 1 to 2 feet tall, and it's really a potent chemotherapeutic. The Native Americans used it for a variety of maladies, and in the last 50 to 70 years, the naturalists and the botanists have capitalized this plant for some of its anti-cancer abilities. And so I always remember etoposide has 2 O's, just like doxorubicin, and it's also a topoisomerase II inhibitor. And so this basically destabilizes the DNA complex. And when that occurs, you see the production of strand breaks, particularly double strand breaks. And this is dramatically unstable for any cell, but especially cancer cells. And so we always say etoposide is a topoisomerase II inhibitor. When DNA is supercoiled, there's a lot of tension, and when this drug is on board, that kind of destabilizes some of these chemical interactions that would otherwise stabilize the DNA molecule. So etoposide has a lot of uses. You can see it used in solid tumors. You can also use it for lymphomas and leukemias as well. In terms of toxicities, as you would think, myelosuppression is typically found when using etoposide. This, of course, is a dose-limiting toxicity. There are some anaphylactic reactions. There's some hypersensitivity reactions that occur in some patients that are taking this drug. And of course, the production of secondary leukemias, particularly in the context of solid tumor use. This drug also can produce hypotension. The second group of drugs include the camptothecins, and so the prototype here is irinotecan, as well as topotecan. So this is another interesting kind of natural products story. These are drugs that are harvested from the bark of a Chinese tree. From afar, this probably looks like bananas. These are not. These are the flowers. This is a tropical and subtropical tree. Again, that is very, very potent in terms of the chemicals that it can produce. Irinotecan has kind of an interesting metabolism. There's a metabolic conversion to this metabolite called SN38. And SN38 is actually about 1,000 times more potent than the parent molecule. And so that potency is really kind of played into effect, obviously in living systems. And so a lot of this this drug has more in vivo activity than what we previously thought. A lot of this was done obviously in vitro before it went into the clinic, and then when it actually went into organisms, animal models and so forth, this drug was found to be quite potent, much to the surprise of the people who were developing it. So irinotecan is a topoisomerase I inhibitor, and this is in contrast to the previous group, which were topoisomerase II inhibitors. And so when you inhibit topoisomerase I, you usually produce single-strand DNA breaks, which obviously aren't as dramatic as the topoisomerase II inhibitors, but you still get a chemotherapeutic effect. And so I always remember irinotecan, irine is number 1, and you produce 1 single-strand break. And you can look at the Roman numeral and compare that to the letter I. And so just visually you can remember that it's 1. Thankfully, there's only one O in here. You can also look at it like that. The other compound that had two O's, you can say was a topoisomerase 2 inhibitor to help you remember some of this stuff. In terms of the uses, you can see irinotecan in several GI cancers. So we will revisit this drug in a future case. It's been used in pancreatic and colon cancer, gastric cancer as well. And unfortunately, the dose-limiting toxicity, ironically, is diarrhea. And so obviously there's going to be a profound GI effect, owing really to the metabolism that we showed you just a few slides earlier. That, of course, occurs in the liver. There is some myelosuppression, of course, that occurs with this drug as well, as you would expect. In terms of the main toxicity for this, for irinotecan, diarrhea will severely impact the quality of life, and in some cases it can be life-threatening. Risk factors, there's a whole list that are listed here. Short bowel syndrome, history of diarrhea, non-compliance with loperamide. There's different polymorphisms that can alter or shunt the metabolism of this drug in some of these patients, and some of those metabolism alterations are listed here. And typically with these patients, you're really going to monitor them a little bit more severely. Some of the main complications, of course, with diarrhea is fluid loss, particularly dehydration, as well as electrolytes. And so you want to kind of keep a real close eye on electrolyte imbalances, as well as overall volume status. This could obviously be a little bit more complex if the patient has maybe something like heart failure or hypertension, and of course if they're on diuretics, of course, this would be quite a complicated case. So these are the main chromatin function inhibitors. They can be used for solid tumors, as well as hematologic malignancies, including leukemias and lymphomas. Thank you.